Today I will be completing my periodontal probe assessment. I have my personal protective equipment on. I have my probe. In school we use the Marquise color-coded probe, which goes by 3, 6, 9, 12 millimeters. The other probe is called the UNC probe. That goes by 1 millimeter markings, and we do not have that in our kit. And then there's also the neighbor's probe, which is used to measure furcation, and we will talk about that after. And then we have our dental mirror and our floss. We have the primary functions of the periodontal probe is to assess the health of the periodontium, and other functions are to measure clinical attachment loss, recession, the width of attachment, size of intraoral and extraoral lesions, any bleeding areas, determine mucogingival relationships, and to monitor the longitudinal response of the periodontium. Before we do any probings on a patient, we would ask them if they've had any gum disease in the past or if they have done scaling and root planing. If they're our current patient, we should have that on file with all of our notes that we do. And then today we're going to be probing 3, 6, and 20. And I will be positioning my patient properly and my light properly. Other functions of the probe. So we're going to go ahead and talk about the furcation areas that's used with the neighbors. Class 1 is early beginning involvement. Class 2 is moderate involvement. You cannot pass through. Class 3 is severe involvement. You can't see it through, but you can pass it through. And then we have class 4 is pretty much the same as class 3, but you can see it and pass through it. You can see it on both x-rays on 2 and on 3 and 4. And then we can measure mobility, which is class 1 is slight mobility up to 1 millimeter horizontally. Class 2 is moderate mobility, greater than 1 millimeter, but less than 2 millimeters. And then class 3 is severe mobility, greater than 2 millimeters horizontally and vertically. And then we're going to go ahead and talk about the clinical attachment loss. When there is recession present, we are going to go ahead and measure the probing depth. That's from the gingival margin to the base of the sulcus. And then we'll go ahead and measure the recession. And then we're going to go ahead and add that. That number is the amount to be added for the gingival level to be back at normal. When there's overgrowth, we're going to go ahead and measure the probing depth measurement. And then we're going to measure the gingival margin level, which is from the CEJ and the amount that's overgrowing the clinical crown. And we're going to go ahead and take that away. That's the amount that needs to be taken away for the tissue to be at a clinical normal level. And then when there's no recession or overgrowth present, we just go ahead and take the probing depth measurement. And then we're going to look at my positions of all the probing depths we measured today. And then we're going to go ahead and whatever we measure today is all going to go ahead and be put into EagleSoft. The proper way, the sequence for probing is that we're going to go from 1 to 17 buccally, 70 to 1 lingually, 32 to 17 buccal, and 17 to 32 lingually. So we follow that sequence every time we're probing every single patient. We need to check for any recessions. Everything is going to be noted on our soap notes. So then when that patient does come back, we have everything noted. And that is our probing self-assessment.